So welcome back to the next episode of Endoscopy Essentials, and welcome back Michał Kamiński. This time we give you colon holiday because we're going into the esophagus. And we don't want to talk about the ordinary, we want to talk about wild stuff, expanding the boundaries, endo-resection. I hope we won't be beaten up by oncologists and surgeons, but let's give it a try. So when we go back 10 years, we were allowed to resect very small lesions with EMR, maybe high-grade dysplasia, and when there was a cancer light, then we were running away. This has changed dramatically. And the first thing is, of course, there are still boundaries, but the assessment of lesions with modern scopes, what do you think? And would you resect anything? So please show us a little bit.
Yeah, sure. Thank you, Thomas, for having me. I mean, it's again a real pleasure to be here, and it's a field that I've told you that I moved out from quality field a little bit because I think that there are many issues that were already resolved, and I think that this is another boundary. We had this boundary of quality. Right now, we have another boundary of resection, and I totally agree with you that in the past, I mean, we were just going out of a room when we spotted a cancer and we referred to surgeon and so on. I don't think that it's happening right now. I think that we are slowly right now changing, but the pace of change will be much quicker. And this is also the reason that I did a clinical oncology specialty myself. So you were saying that, I mean, we don't want to blame or you know, get angry with all oncologists and so on. I'm a clinical oncologist as well.
Okay, so
myself.
You have to get angry with yourself, maybe.
Yeah, so I think that...
Show us an example.
Yeah, so this is the first example, and this is a lesion which in my practice, we commonly get a referral from somebody who said, oh, listen, there was a small bump in a cardia. So, you know, I took a biopsy and you know what? I mean, there is a cancer on biopsy and they are still a little bit frightened with that. And then this is a situation in which I get excited because honestly speaking, with modern scopes right now, you can see really a lot. And it's a really amazing technology. And this is just an example of how a small cardiac cancer without any Barrett's in here, but probably with also some intestinal metaplasia around, which they usually have, may look like. And
it's not so small after all.
Yeah, I mean, it's not...
Where would you set the boundaries, circumferentially wise? There are these accompanying bumps, are they normal or would you...
Yeah, I think that those around are probably normal, but usually in the cardia, we tend to have a really decent margin when we want to resect something like that. And the reason for that is that you do not predict any significant stricture. I mean, in the cardia, once you expand, you will have a decent margin and it won't occupy more than half of circumference.
Because on the left side, what really looks normal is between 12 and 7, huh?
Yeah, I would say that between, let's say, for sure 12 and 7, but what I would really like to focus your attention to is something that is happening on the 3 o'clock. So there is certainly a depressed part. This is a first thing. Then the second part on the right-hand side is a demarcation line. So we try to say that in the stomach you will see a demarcation line, but also in cardiac lesion, you will see really clear demarcation line. I mean, once you get to know how it looks like, and it looks exactly like this one, you will see those lesions. And obviously, you cannot cut just above the demarcation line, so you really want to have decent margins. The other aspect, which is quite important for the cardiac lesion, is that it usually or quite often undermines squamous epithelium. And this is also a very common characteristic, which should also focus your attention. Whenever you see something like that, just look carefully.
But wait a bit. I mean, let's go 10 years back.
Yeah.
We wouldn't have touched that, right?
Yes.
So what's your limit now?
I think that in terms of limits of a size, there is no limit of size.
But depth?
Depth?
However you can assess it, and maybe you can't.
Yeah, that's really important. And I have an example for squamous cell esophageal cancer that I will show you in a moment. And obviously depth was also another boundary for quite some years. First was a size, obviously, and a cancer itself, which we were really frightened of. But the second one was a depth. And obviously for quite some years we were thinking, oh, depth. I mean, we cannot resect those cancers because they are deeper, so there is an increased risk of lymph node metastasis or distant metastasis and so on. But I think that the field is changing right now, and it's really important. And this is why I did a clinical oncology specialty, because we are going to have this multimodal treatment, which means that you will combine local resection with endoscopy with neoadjuvant or adjuvant treatment. So this is already starting. We are not there yet with all of robust evidence, but there is increasing evidence, and probably for squamous cell of esophageal cancer, this is already there for chemoradiotherapy.
Okay. I'm getting nervous. So,
okay.
So, I mean, what are the limits? What do you do for staging? What happens if this is really a hard lesion? What happens if there's a slight stricture? Maybe patient is still asymptomatic, but when you pass, it's hard. Is that a sign not to do it? Do you do EUS, CT?
Yeah, I mean, there are obviously some common problems, and cardia cancers or esophageal adenocarcinomas are difficult to predict based on advanced imaging in terms of depth of invasion, and obviously you have to rely on your expert eyes and mostly on macroscopic appearance. So if it doesn't move really, if it has a contact bleeding, fold convergence, and so on, a stricture. I mean, these are the signs which makes me nervous. Then I get nervous. I don't get nervous with this kind of a lesion.
So that means touching is more important than looking?
Yeah, I mean, you can also look. I mean, if you are gentle enough. I think that in order to be a good endoscopist, you have to be a gentleman and behave gently. Yeah, you can. Yeah, you should touch gently. But then obviously you asked me about like EUS or some other imaging modalities. It's also in the guidelines, but EUS is not really good to differentiate between T1 or T2 cancer at all, and especially to differentiate T1A or T1B. I mean, you can't make it happen. But obviously, my approach is whenever the lesion, I think, is not amenable for endoscopic treatment, but it's on the bedside, then I will do EUS, because sometimes we get surprised, and then if EUS clearly says, okay, this is really superficial, because they sometimes look really difficult for assessment on white light or advanced imaging, then I may tend to assess it. And obviously what we really want to look at in this kind of situation is lymph nodes, and we will also want to have a CT or PET CT, especially for squamous cell esophageal. I mean, then we would need some advanced radiology as well, I mean, to look at lymph nodes and distant spread.
I mean, there were 2 recent studies showing that the endoscopic differentiation between TA1A and B is miserable, and EUS tends to overstaging. So we have a little bit of a dilemma here, and I think we have to redefine our criteria, or maybe do you think we end up at the old surgical principle, in doubt, take it out?
I'm not sure. I think that we have to develop the field further, but we are not there yet. Sometimes, I mean, we tried to figure out for quite some years. We don't find an answer, and we think there is no answer, and then there is a simple answer which will help us quite a lot. So I think that there will be some answer over time, but in most cases, and it rarely happens, that you encounter a lesion that you start dissecting and that it will be a T2 cancer, so you cannot take it out. It may turn out to have some high-risk features, but to have a lesion which is really a T2 cancers once you start it, if you have your experience, I don't think that it happens really often, or very rarely.
Okay, so let's get to squamous, which is believed to be even much more dangerous.
Yeah, I think that there is a belief, and there are some proofs, obviously, from oncological standpoint. But here, and I will play this video, which is a very nice one as well. So we also tend to miss lesions easily with white light endoscopy. You can see it already on the left-hand side in white light. And right now it becomes much easier to spot the lesion on NBI. So already what attracts us and what should attract us is this brownish background discoloration. This is the first thing which catches our eyes. And then the second thing is that inside this brownish background discoloration, there are these dots. And these dots are so-called Intra Papillary Capillary Loops. So these are just, small vessels which, with increasing advancement of a lesion, they will also increase in size and differ in diameter. So here you will have a nice example. You can see even almost with white light partially, but in a moment we'll see it much better. Right now we see it really quite clearly. I will stop this video and you will see that there are some regions, some parts of the mucosa without vessels. Some vessels are dilated but are still in a form of a loop. Some are elongated already. So based on these features, you can try to predict the depth of invasion, which is quite different as compared to what we have for adenocarcinoma, in esophageal adenocarcinoma or cardia cancer.
So what would you predict here? I mean, you probably know the histology, but it looks ugly anyway.
It looks slightly ugly, but I would predict superficially invasive squamous cell cancer. And this is certainly something that after additional staging, so PET-CT or EUS, just looking for more for lymph nodes, you should try to resect, or if you cannot resect, you should refer to somebody who can resect it.
Okay, so no boundaries again, and it's flat, right? So everything which is flat can be amenable to endotherapy potentially.
I wouldn't say that everything that is flat, but certainly, I mean, we got much more used in the colon that, I mean, if it's depressed, it's bad. If it's sessile, it's fine. It's totally opposite for squamous cell esophageal cancer, for example. If you have a sessile component, usually this lesion is not amenable for endoscopic resection, because usually you'll see this really large vessels crossing this, sessile part, and this will be a deeply invasive lesion. But everything that is really completely flat or slightly depressed, I mean, most of it is really amenable for endoscopic treatment. And in terms of size, I don't think that nowadays there is a limit in terms of size of what you can resect. And especially if you compare it to surgery, which, I mean, esophagectomy is something really that we wouldn't like to experience ourselves for sure, and we wouldn't like our patients to experience as well if we can treat them with local resection. So certainly we can make it happen without any size limits, honestly speaking. And
okay, so both lesions EMR is far away, right? So it's now these lesions, if we talk about boundaries, it's all en bloc, or attempts for en bloc ESD, right?
Yeah, I mean, for squamous cell esophageal cancer, we have quite good evidence to support en bloc resection by means of mostly ESD. For Barrett's lesion, I mean, there is still this is still debatable. If you look at the guidelines,
this type of lesion at the cardia, no way. Huh?
No, this kind of lesion in the cardia, no way. Though, I mean, if you look in the guidelines, I mean, it's not really. I mean, we are not really sure if we should, apply Barrett's guidelines or gastric cancer guidelines.
The problem of guidelines is they pretend to know histology.
Yeah.
Which we don't. We know afterwards. Yeah. So it's probably, if we push boundaries, we should take our best weapons, and that's likely to be ESD. Okay. Yeah. So what's your ESD technique?
Oh,
show us an example.
It depends, but certainly for this kind of lesion, and this is a different patient as compared to the previous one, but also an extensive lesion. So I will show you a brief overview. So this is a full circumferential lesion extending over 12 centimeters and starting at the upper esophageal sphincter almost. In a young patient, actually, which really rarely happens, but without any, let's say, risk factors, epidemiological risk factors.
An absolute no-go 10 years ago, huh?
Yeah. So you can clearly see with advanced imaging a upper limit of a lesion. So you can see on the right-hand side, this is a normal mucosa. Then a little bit lower, you see this brownish background discoloration with enlarged Intra Papillary Capillary Loops. And there is no near focus, dual focus, no additional tool that you need for that, because I mean, even from a distance you can see that these IPCLs are out there. Obviously, I mean, to stage them you would need a better visualization, but you can see it also with a regular scope. Yeah, and obviously, I mean, 10 years ago we wouldn't touch it, but right now I think it's worth a try. Because, I mean, prognosis for this kind of patient is dismal, because, I mean, if it extends to the proximal esophagus, this patient would just be offered radiotherapy for this lesion.
Which can be curative as well.
Yeah, but most of this lesion is high-grade dysplastic lesion that you will see, and I also know the histology, so I'm smarter afterwards in terms of knowledge of what happens. So what you can see, you can mark the proximal and distal margin. Here you can see how big is the lesion. And for this kind of lesion, I mean, you cannot resect easily. I mean, you have to have a special technique. And what we've applied here is a tunneling technique, which follows a little bit of a principle of POEM. So right now everybody knows POEM. So you try to enter into the submucosa. I will just speed it up, and you create a tunnel. And you try to, I mean, think as well about the gravity. So you create a tunnel also on a gravity side, on the side where you can see the most advanced part of the lesion, so that you can make sure that you go underneath the lesion itself, under the tunnel, because it's easier. So you can see that we create the first tunnel and we pull back the scope. Here we have 2 lumens. We continue with a dissection. We create the second tunnel, and right now you will see 3 lumens in the esophagus. So this is the second lumen that we are seeing, one and the second, and then in a moment, this is the second tunnel, so 1 and the second tunnel, and then it becomes really simple. So if you use a tension, you just connect those tunnels step by step. You touch, you can be very gentle just above the muscle layer. You shouldn't be very, very close to muscle layer, because you can probably induce more stricture, because this is obviously a problem with this kind of resection in terms of limitations. But this is more or less how it looks like at the very end. So this is how the lesion looks like. So you can, in terms of size limits, I said that there is no honestly speaking, limitation, and it's also not so time consuming, honestly speaking, right now. Nowadays it would take probably around 2 hours, so it's not bad.
Okay, so we don't talk about strictures because that's a separate topic, how to prevent, and there are some possibilities, because again, years ago it was 100% stricture rate, it's not anymore. Okay, so that's one boundary. Sometimes patients coming with recurrences after endoresection.
Yeah.
I think you have an example as well. And previously, again, we said, okay, we had our shot, now patient goes to surgery.
Yeah.
Not anymore.
Yeah, I think that, we were using, we had less knowledge, less skills, and also I think that we were using lots of our eminence in terms of what we did with the patient. So I think that we have to communicate with the patient, and we have to be multidisciplinary in this field. So we have to introduce those patients with recurrences to multidisciplinary team. I mean, you have to discuss different options. You have to discuss these different options also with the patient. And obviously, there will be some patient preferences, especially when there are comorbidities. And this is an example you asked me, to share with you an example. So this was a patient who underwent a full circumferential resection of Barrett's cancer, an extensive resection as well, and it was very nice.
Using EMR?
No, using ESD. Using ESD. So he healed quite well, and over a year everything was fine. And then we got this finding that you can see on the left hand side.
Resection was R0?
Resection was R0 at the time of resection. So recurrences
can happen.
Yeah, recurrences can
Not
happen.
frequently, but they can.
Yeah. So we felt, looking at it, that it's like a Barrett's lesion. It is surrounded mostly by neosquamous epithelium. It's a small lesion. The patient was really not very fit for surgery with severe comorbidities. So we felt, okay, we will give it a try. Would you? It's tiny.
Now, yes, of course.
Yes, but so it's small. Okay. Does it look
But maybe deep.
You think so? Why would you say so?
You never know. ESD after ESD can be fun.
Yeah.
And various degrees of scarring and remaining submucosa or not. So you never know what to expect.
Yeah, that's true. That's what really happened in here. So we didn't expect. We spotted this tiny lesion. We thought, okay, it's going to be difficult because it was a full circumferential dissection. There is going to be lots of scarring, and obviously, what we have seen at first was lots of scarring. So you can see really fibrotic submucosa with some, muscle layer which is just already trying to attach to the submucosa. So a very difficult submucosal dissection. But obviously, we said, we are breaking boundaries. So we said, okay, this is not a big deal nowadays. You can go even underwater. This is very trendy right now. And this is the view underwater that we encounter on our way in. So you can see on the left-hand side that once we arrived at the level of a recurrence, you can see that the recurrence is really attached to the muscle, and not only to the superficial part of the muscle, which is in this higher part. And we know from POEM that we have obviously this circular muscle layer and longitudinal muscle layer, and obviously longitudinal is very, very thin. Nevertheless, we felt, okay, this gentleman is not a candidate for surgery at all. Ablation, what can we do? So we decided to push the boundaries further. And it's not only that we do a crazy stuff, but we took into account, we discussed with the patient, with the family and so on, and we decided to go even deeper. So you see that there is a tiny invasion of a muscle layer, and right now on the second one, you can see in the second picture that we just cut out the lesion entirely from the muscle layer. So we intentionally created a perforation in the esophagus. But we were sure that this is small, that the patient is with CO2 under intubation, that we have anesthesiology team with us, everything was prepared, and we had also a very nice thing, which is the patient underwent full circumferential resection, so there was a little bit of narrowing of esophageal lumen, so we decided upfront to cut it out entirely and place a stent immediatly.
Was there a visible hole, or?
Oh yeah, there was a visible hole of around 10 millimeter in size in the esophagus.
Which you may see through the stent a little bit.
Yeah,
yeah.
Yeah.
Okay.
So you see the resection, and in the middle you can see you can see the hole. And honestly speaking, there was in this patient no fever, no CRP elevation, nothing just happened. I mean, we were obviously worried, and you have to make sure that you can take care of this patient. And obviously, we had this patient in hospital for quite some years, some days, to be sure that everything went well. But actually, it happened, I think, already 2 years ago. There is no recurrence with this patient. This was our R0 resection, and this is how we will probably in the future push the boundaries on a daily basis, because if the patient would be a candidate for adjuvant treatment, we'll probably add on some adjuvant treatment to this kind of multimodal therapy for our patients.
Okay, so this was crazy stuff. If we put it into perspective from an endoscopic side, I think we get away from all these histologic criteria except for R0. So the holy grail is R0, right?
I don't think
you
that...
have to, if you don't get it out completely, then you probably have to do something else like surgery. But the main aim is to have a complete resection.
I think that R0 resection, the deep margin is very important.
Yes,
I mean, the lateral margin is not that important. Obviously, what we take into account is obviously, grade of differentiation, LVI. Right now, we do take it into account because, I mean, you may have a different...
No, I agree. Sorry to interrupt you, but, you said endoscopy is not the only thing.
Yeah.
Because the old thinking was endoscopy has to be the only thing. We are alone at home.
Yeah.
So we have to deal with ourselves, and that's why we can only resect very small lesions, superficial lesions. Now we are in a consortium. We are in a multimodal setting, as you said. But our task is to fully resect this thing, right?
Yeah. Yeah, this is our task, and this is also, I mean, to deliver surveillance afterwards and to discuss with the patient and so on. And we have, I mean, when you think about multimodal, I mean, it means that also active surveillance for some patients in certain, not in this kind of situation, but in some situations could be an option. Active surveillance and surgery in a situation when there is a recurrence, because this is also something that we didn't consider beforehand. But if you take into account patient preferences and increasing knowledge in terms of metastatic spread with certain risk factors, so we have to learn more and more about it.
Right.
Then you can probably make a good choice.
So if you have your local resection of the tumor, then you deal with the lymph node risk, and this is where the multimodality comes in, right?
Yeah.
So adjuvant therapy or whatsoever.
Or surgery, or whatever. It will depend on the situation.
There is selective lymph node surgery. There's a whole spectrum. But I think it shows that the boundaries are expanding. But of course, there's a significant warning. You are an oncologist, as you told me, so there have to be proper studies. So the oncologic aspect, the oncologic safety has to be balanced against the things we are doing. What we are doing is safer than major surgery, but the oncologic safety should also be guaranteed, right?
Yeah, indeed. I mean, if you look at the guidelines, I know that you don't like the guidelines, but many endoscopists or physicians are following guidelines, international guidelines. And if you look especially at oncology guidelines or surgical guidelines, there is very, very little about endoscopic resection, wherever you look at. And one of the reasons is that we were really, really poor in terms of providing good quality evidence and comparison between surgery and endoscopic treatment. But this is going to change. We've created a consortium in which we are going to change this situation, at least or at first for colon and rectum, but I'm quite sure that also for all the other GI cancers it will follow.
Right. And I think what we have been traditionally doing, and we were discussing this with many people also in other podcasts, so we accept a very low oncologic risk only, but we accept a much higher interventional risk. So this balance has to be rethought, and I think there is much more to come, and there has to be proper research to be done. So that's really a plea. But I thank you very much for these exciting images and how we are to go. So let's see how much we are beaten up by the other disciplines. And again, Michał, thank you very much.
Yeah, thank you so much, Thomas. Thank you.